This is Dr. Howard Strassler with an e-lecture on decision-making and restorative interventions, Module A, Class 1 Caries and Preparation Design Considerations. Let's first look at what we already know about Class 1 Pitt and Fisher caries. It includes the posterior occlusal surfaces, the buccal and lingual surfaces of posterior teeth, pits and fissures, and the lingual pits of anterior teeth. That its typical appearance is a progression of caries where two cones or two triangles are base to base, where the caries initiates at the tip of one triangle and it progresses towards the pulp through the dentinal tubules to the other tip. It's a very typical schematic of what Pitt and Fisher caries looks like. Let's take a look at restorative interventions for Class 1 occlusal Pitt and Fissures. That really we can break it down into three distinct categories. And occlusal pits and fissures we're referring to the presence of no Class 2 or interproximal caries. In the first scenario, there's no caries at all. We see the clinical signs of pits and fissures, and we'll make a decision to reevaluate or active surveillance or place a sealant. And there are a number of factors that help us make that decision, and we'll explore those decisions. In the case where we see minimally isolated carious pits and fissures, where they're not very extensive, we're going to consider a preventive resin restoration. And we'll talk about the minimal intervention required for preventive resin and what the technique and preparation design features really encompass. As pits and fissures become more extensively carious, we're looking at more conventional preparations. It's very similar to what you did in your first year preclinical course. We'll be looking at restoring these directly, either with composite resin or with amalgam restorations, following the principles of cavity preparation that we've reviewed in the past. But really the greatest challenge we have when it comes to viewing, to evaluating, to diagnosing whether or not pits or fissures are carious is making the decision when to intervene. It is one of the most difficult challenges we have for something which appears to be very minor. When we look at these clinical pictures, we can see that there's discoloration in these pits and fissures, that in some instances they aren't continuous into the central grooves, into the buccal and lingual grooves, into buccal pits or into lingual grooves, but in fact are very distinct. There are colorations, brown, a little bit of white, and then really some of the most important questions that we need to ask aren't told to us by just looking at these clinical images. How old is the patient? What's the caries risk? The diet of the patient, past dental history, age of the patient. All of these things become extremely important factors in making our decisions. And so we take a look at how do we make these decisions? How do we treat? How do we design our preventive treatment strategy in the diagnosis and our management of fissure caries? And this line drawing, it as complex as it is, was adapted from your Summit textbook. And it really refers to the decisions that we make, and here we're looking at the enamel caries paradigm only, what's happening within the enamel. And we break it into several different categories. In this first category, we're looking at the enamel looks normal. We see no color changes in the pits and fissures. And we're going to make the decision as to how we're going to intervene. For mature teeth, older teeth, our intervention, and keep in mind we're looking at sound enamel. It looks normal with no color change. And for mature teeth, for our older patients, our patients in their mid to late 20s, 30s, 40s, and beyond, for sound teeth, no caries, we're going to do active surveillance, what we refer to as watchful waiting. We'll have recall, reevaluations, and checkups once every 12 months. And we'll evaluate for sealants every 12 months. In fact, for our older adult patients who demonstrate a very low caries risk because nothing's happened within the pits and fissures, we'll probably never do an intervention. It may pick up discoloration over time, which is normal, but no intervention is necessary. When we take a look at the younger patient, when the tooth is just first erupting in the mouth, or it's been erupted in the mouth for less than 5 years, we need to do our caries risk assessment. Look at those criteria as it relates to low, moderate, and high caries risk, and make decisions as to how we're going to intervene. Intervention can be as routine as for a low caries risk, watchful waiting, active surveillance as to what's going on with routine checkups every 6 months. And for our younger patients, we're going to have more frequent checkups because we know from our historic data and from the evidence that these patients are at greater risk. A patient with a moderate caries risk, we're going to do some level of preventive treatment. We're going to be using fluorides, prescribing fluoride mouth rinses, making sure they use fluoride toothpastes. We're going to do more frequent checkups because there is a moderate risk based upon the number of restorations they have placed, the past history of caries experience. And we may see them every 1 to 6 months depending upon the risk that we see. For the patient with pit and fissures in their posterior teeth that are at a high risk, we're going to take some more firm intervention. We're going to consider placing an adhesive sealant in those pits and fissures. We're going to do our preventive treatments of fluorides, oral hygiene instruction, rinses, high fluoride toothpaste, and the more frequent checkups to get them past these higher risk years. What about when we see discolorations, opacities, we see changes to the enamel surface from when the tooth first erupts in the oral cavity? Our preventive treatment strategy for the diagnosis and management of fissure caries becomes more complex, as you can see by this flow chart with all the arrows and all the different directions those arrows are going. Let's take a look at when we see a white opacity that's only visible after air drying. Is this a demineralization lesion? Is it occurring on the cusp ridges into the existing fissure? And then we look at a tooth that's been in the mouth a longer period of time, the older tooth, the tooth that may be in the mouth for 5 to 10 years, and we're going to make an intervention. We're looking at the caries risk. Is it low? Is it moderate? Is it high? And in fact, that helps us in making our decision. And our decision is very similar to, for enamel caries, very similar to that we saw when we saw no color changes and the enamel looked normal. In low caries risk, we're doing our active surveillance, our watchful waiting with routine checkups for this younger patient at every 6 months. As the risk becomes moderate, we're doing some levels of preventive treatment using fluorides, oral hygiene instruction, fluoride rinses. We may be using fluoride varnishes. We're going to do more frequent checkups, so maybe every 1 to 6 months, depending upon the risk and the progression of lesions within the mouth. For the high risk, we're going to intervene to pits and fissures with a sealant, a more invasive treatment, a restorative treatment. Our preventive treatments of fluoride varnishes, fluoride toothpaste, fluoride mouth rinses are in place, and a more frequent checkup of 1 to 6 months. We're making the decision that this is active enamel caries. It may be more slowly progressing. Dark discolorations we look at a little bit differently. For the young patient, our caries risk assessment even at a low caries risk, puts us in the preventive treatment category because of the fact we see a dark discoloration. Our high risk, in fact, still requires we place a sealant. But keep in mind, for all the levels of our evaluation for our diagnosis, the patient's caries risk helps us in making our decision for this enamel caries paradigm. So we've been talking about occlusal pits and fissures, what's happening to those occlusal surfaces. And consider this. 12.5% of all tooth surfaces are on the occlusal. And yet, of those occlusal surfaces, they're responsible for 2/3 of the total caries experience for children. You can see why we want to intervene sooner, why we want to do more frequent checkups for our patients. And we think, what preventive measures should we take to decrease the number of carious lesions on occlusal surfaces? What active participation will we do as practitioners? And consider the occlusal surface, its invaginations. It defies access by the toothbrush. Look at what one toothbrush bristle looks like compared to the invaginations within pits and fissures. When a parent says to a child who needs a restoration on the occlusal surface, I told you should have brushed your teeth, brushing isn't going to help worth a darn. That it needs our intervention, our guidance to prevent those class 1 lesions. The anatomy, the surface topography of pits and fissures are like valleys, like the Grand Canyon to the bacteria. Whether it be an occlusal fissure and its invaginations and the depth of those invaginations, or a buccal pit. And keep in mind, the environment for these pits and fissures is very different, because to our left, these occlusal pits and fissures are going to pack food, organic plugs. When we talked about caries as an infectious disease, we spoke about those organic plugs and how caries progresses in these teeth. Versus a buccal pit with the same invaginations, the same topography, may never decay because nothing's being forced within it. The bacteria aren't made stagnant within those pits and fissures on the buccal. We see different types of fissures, from a narrow eye-shaped fissure that's branching at its base, where when the bacteria are forced into these fissures, they cause demineralization and progress to the DEJ and then progress into the dentin. These are very at-risk pits and fissures, teeth that are susceptible to pit and fissure decay. We compare that to a very shallow V-shaped or U-shaped fissure, which is at lowest risk of developing caries on an occlusal surface. And in fact, our judgments whether to place a sealant are changed based upon those topographies. And so we review the progression of caries, and we talked about the traditional model. And on the left, the traditional model is demineralization in the cusp ridges, demineralization into the pits and fissures, into those invaginations, following the cuspal inclines, and then progressing to the DEJ. We see the color changes on the enamel surfaces. We see an opacity, a white opacity occurring as the demineralization occurs. We see some staining of the pit and fissure. In fact, it's a sign for us that things are happening, especially for the young patient. Now we take a patient where the fluoride has made the cusp ridges resistant to demineralization. Yet, as we pack food into these invaginations, into these pits and fissures, we create an organic plug. We have the bacteria get within those pits and fissures. The enamel becomes demineralized. It reaches the DEJ and the dentin becomes demineralized, and in fact the bacteria, the leading edge, follow the dentinal tubules as they head towards the pulp. You see caries progressing at this fissural base with a lateral spread at the DEJ. We refer to this as the hidden caries model. Some people refer to it as fluoride caries or covert caries. It's basically fluoride protected enamel on the occlusal surface. Doesn't show evidence of any cavitation or anything happening, and yet the caries is progressing at the bases of these pits and fissures. So we see changes to the occlusal surface and we make a decision. How are we going to intervene? How are we going to make our decision? And we can really divide, when we evaluate teeth, when we evaluate patients, we can break them into categories. We can look at the young tooth, the tooth that's just erupted in the mouth. It's in the mouth for less than 10 years. A child, an adolescent, someone in their early 20s. And we start by looking and evaluating caries risk. We'll also be looking at the pit and fissure anatomy. Is it invaginated? Is it a groove? Is it a susceptible pit and fissure? Do you notice color changes, staining, brown, white opacities, changes in translucency? For this young child, what's the fluoride history? What's the history of varnishes, in-office fluoride treatment, their dental care, and their regular dental visits? How often are they cleaning their teeth, and how are they cleaning their teeth? Is it a high sucrose diet, a high carbohydrate diet? Are there acid ingestions? Are there things that put that enamel at risk? And then when you evaluate the patient, it's more than just one area. It's all the teeth. It's the internal cavity, all tooth surfaces. Are there other restorations? Has the patient had past risks that have needed some restorative intervention? This helps us in making those decisions. And those decisions are very different when we look at the more mature tooth, the adult patient, and we look at these clinical images of pits and fissures in a patient in their mid-50s. We look at the patient's caries risk. Have they had carious lesions? And when they have had carious lesions, are they pit and fissure carious lesions, or are they smooth surface? Are they class 5s? Are they interproximal caries, class 3s, class 2s? Once again, caries risk comes into play as to how we intervene preventively, restoratively. Now we look at the pit and fissure anatomy. Is it invaginated? Is it a groove? Is it self-cleansing? We look at staining and color changes. Is it brown? Is it a translucent enamel or a more white opaque enamel? Do we see demineralization occurring? The patient's fluoride history. Are they ingesting fluorides with their toothpaste? Are they using fluoride mouth rinses? Are they using calcium phosphates? What type of toothpaste are they using, and how often are they cleaning their teeth? Is their diet high in carbohydrates? So all the things that we've talked about, and it relates directly to caries risk. What sort of acids do they have in their diet? Are they taking in soft drinks, perhaps energy drinks, iced tea with lemon? Is the enamel being attacked chemically by acid erosion? And then once again we look at the presence or absence of other restorations to give us an idea whether pits and fissures are at risk, and we make those judgments. And so then we consider restorative interventions. And it's all based upon risk. And in the situation where no caries is suspected, you look at a young child, an adolescent, you see an erupting tooth, a 6-year-old patient, and the first permanent molar is erupting. Our consideration is the placement of a sealant. We don't want to wait for caries to occur. We don't know if it'll become carious, but it's minimally invasive to place that sealant. For the adolescent, the 12-year-old, the eruption of the permanent second molar. In fact, we know sealants are best placed on permanent first and second molars, and most of the evidence and studies have been done on that population of 6-year-olds and 12-year-olds. We're looking at first to third graders who are getting sealants placed in school sealant programs. Once the tooth's fully erupted, we reevaluate it. And keep in mind, when we place a sealant, the sealant is not forever. We may need to have to reapply sealants. If we see pits and fissures that are suspicious, we may decide to go in with a small burr do an odontoplasty to evaluate whether or not we see some initial caries forming in pits and fissures, and we may open up those pits and fissures and still place an adhesive sealant in that area. And this is for the child and for the adolescent where no caries is suspected necessarily, but we want to intervene so that no caries occurs. Remember, 2/3 of the caries experienced for children is in pits and fissures. Now we take the young adult, the adult patient, someone in their 20s, 30s, 40s. It's a mature tooth. It's fully erupted. We have seen past history of restorations for that patient by the other teeth that they have. We're going to reevaluate those teeth. We're going to clean them. We're going to dry them. We're going to look under magnification at the dry surface. We look for color changes. No, we're not going to poke and explore in and wiggle it around to see if we get a stick, because that's not a real good indication of the presence of pit and fissure caries. For this fully mature tooth that's fully erupted in an older patient, placement of a sealant is unlikely. In fact, if we do place sealants, our consideration is changes in the occlusion. We're going to be building up that occlusal surface over the cusp ridges. It's not just painting in the pits and fissures. In order to have sealant durability, we know it needs to extend onto the cusp ridges and have a thickness of 0.4 of a millimeter. If we see suspicious pits and fissures, we're going to open them up with a small burr to evaluate whether or not we should place a sealant, and we create room to place that sealant. What about when we have the diagnosis that there is pit and fissure caries? For the young tooth, we're going to do for minimally isolated caries in isolated pits and fissures on the occlusal surface, we're going to do a preventive resin restoration. Small preparations, etch and rinse, adhesive, light cure, flowable composite. If the caries extends into the pits and fissures of this young tooth, and we're talking about a teenager, a 20-year-old, that we're going to do a more conventional preparation, and we're going to restore with either composite resin or amalgam following the cavity preparation principles that we've learned in the past. The mature tooth, when caries is diagnosed for class 1 occlusal pits and fissure decay, we're doing the same thing. Minimally isolated caries, we're doing a minimally invasive cavity preparation design with a small burr, removing only where the caries is present in those isolated areas. We're etching the entire occlusal surface, placing an adhesive and a flowable composite for a preventive resin restoration. The more extensive carious lesion into the pits and fissures, our extension for prevention will be a more conventional cavity preparation design, fulfilling the requirements for cavity preparations for a filled composite, a nanohybrid, or for an amalgam restoration. And all of this really fits with our carious lesion continuum. Keep in mind that in the mouth, the enamel is always under caries acid attack. We see a constant equilibrium of remineralization and demineralization, where the saliva plays an important protective role. But there's a time when this equilibrium is shifted, and there's a need for a restoration, because if we take a look to the left, we have a sound tooth and no caries and no demineralization. Everything's remineralized, everything's just fine. But now we track changes and we start to see a shift in this equilibrium to where the tooth is demineralizing. It starts with histologic evidence of caries in the enamel surface. It moves to and progresses to where on a radiograph we see evidence of the caries progressing through half the thickness of the enamel, whether it be pits or fissures or smooth surfaces, until finally radiographically we see definite enamel caries. We see it radiographically. In fact, if we were to section the tooth, we'd see that the dentin's been affected histologically. The enamel surface is still intact. We may see discoloration, some white opacity, some white spot lesions, but there's definite enamel caries. the leading edge of the bacteria that have penetrated and made the enamel porous are now penetrating histologically into the dentin at the DEJ. Finally, as it progresses and we continue to see the demineralization, we see definite dentinal caries radiographically. The enamel surface is still intact. In fact, we can still remineralize and stop the need for a restoration. But if the progression continues to a demineralization where you see enamel cavitation, loss of enamel surface, roughening, cavitation of the surface, our intervention becomes a restoration. And we can't reverse this cavitation within the tooth, the patient having a cavity. And so we look at a couple clinical scenarios. A minimally isolated carious lesion on the pits and fissures, and if you look at the mandibular first and second permanent molars to the left, you'll notice that these teeth have cavitated lesions. The pits and fissures, some discoloration, but they're in isolated areas. We've diagnosed caries, and our preparation design is very minimally invasive. In fact, it doesn't look like our typical convention design. We've not prepared some of the pits and fissures. We've only prepared those isolated areas that you've seen to the left with small minimal preparations, perhaps prepared with a number 1 round burr, a 330 burr, a flame-shaped diamond. Our restoration will be an acid etch with a etch and rinse adhesive, a light cure, and then a flowable composite over the surface as we see here, and the flowable composite covers the entire occlusal surface, so that the flowable composite is both our restorative composite and our sealant all in one for our preventive resin PRR restoration. As the caries extends, we extend our preparation. We want to remove all susceptible pits and fissures, all carious pits and fissures. Well, we're going to follow a more conventional extension for prevention preparation outline form. Our restorative material can be either composite or amalgam as we extend into the pits and fissures that we see that are carious. And this extension for prevention really is that the carious lesions progress through the enamel into the dentin. That when we do our conventional cavity preparation, we're going to leave right angle cavity surface margins. We're going to remove any unsupported enamel. We'll prepare those areas where the caries is extended into the dentin. And when we remove the caries, we then will go ahead and then place our restorative material following the techniques we know and understand. So this whole idea of caries extension based upon preparation design, that we're going to make our diagnosis based upon our radiograph, based upon our clinical image to make our diagnosis. For this patient, we can see very subtly that the caries has progressed past the DEJ, and we can see it on the bite wing radiograph, which is the diagnostic radiograph for caries for posterior teeth. Clinically, we can see that the occlusal surface is cavitated. Our preparation design is very conventional, and on the right-hand side you can see we've taken our 245 burr and we've extended the preparation into the pits and fissures, into the fossas, into the buccal and lingual groove. In the isolated area near the lingual groove and the central fossa, we can see the caries has progressed further, and it parallels the image that we diagnosed from the bite wing radiograph as having dentinal caries. We'll remove those caries with a number 2 round burr with a slow speed handpiece. But notice there's still discoloration on the pulpal wall. We can use an explorer to determine the hardness of the dentin. If the dentin can be penetrated, it's still sticky, it's tacky to the explorer, we're going to remove that dentin, unless for this vital tooth it would lead to a pulpal exposure. We can know our depth by taking a periodontal probe. comparing the depth to the cava surface margin, and looking at the radiograph and comparing that depth and the extensions of the carious lesion relative to the pulp chamber. Our decision to do an indirect pulp cap would be based upon, is the tooth vital? Is the tooth asymptomatic? Radiographically on a periapical, do we see no evidence of a periapical pathology? In that case, for a very deep carious lesion, we might do an indirect pulp cap, following the principles we described in earlier seminars and lectures on direct and indirect pulp capping and vital pulp therapy. Or for this case, making a diagnosis from our bite wing radiograph and from our clinical appearance. And you can see from the clinical appearance this tooth has a definite cavitation on the occlusal surface. You can see coloration changes in this tooth, that there's darkening beneath those cusp ridges. In fact, if we look at the arrows in the radiograph, we can see the dentinal caries on the bite wing. And we notice there's a lesion on the distal surface. That's carious. Now, perhaps a third molar was removed and injury was done to that tooth with a burr during the sectioning of a third molar. Perhaps there was a third molar present on that distal surface that was tilted, causing food impaction and retention. But there's a definite distal carious lesion that's not evident from an occlusal view. Our caries extension helps us define our outline form in our preparation. We make that determination from the bite wing radiographs, the appearance of the pits and fissures, and that will help us define our outline form for our preparation, our extension for prevention. And so from the evidence in the radiograph of occlusal caries and proximal caries on the distal, we're going to do our preparation. And from an initial cavity penetration, you can see where we're going with this preparation. It's going to be more extensive than what it appeared clinically originally from our diagnosis. How good is radiographic detection of occlusal caries? Well, we take a look at one of the benchmark studies at looking at radiographic interpretation of occlusal caries, where 10 experienced operators were asked to look at radiographs made of extracted teeth, 82 molars and premolars. All those teeth had the appearance of occlusal caries. After the evaluation was done, the radiographs were made, the teeth were sectioned and evaluated. Through the sectioning, they could determine that 24 of those teeth were sound, had no caries at all. 32 had enamel caries, and these were cross-sectional slices of the teeth. 13 had caries limited to the outer third of the enamel, of the dentin, and 13 had large dentinal carious lesions. And so the operators evaluated the radiographs, and then that data that was collected was compared to what was found with those teeth. How good were we? And this was a research study that was published in Caries Research in 1994. Well, from the diagnoses that were made, 12% of the sound teeth having no caries were wrongly diagnosed as having caries radiographically, a false positive. 21% of the carious lesions were diagnosed to the dentin when in fact they were only enamel lesions. One operator performed the poorest, and he misdiagnosed 55% of the surfaces that were sound or had enamel lesions. They were wrong 55% of the time with these radiographs. The best performance was one operator who had false positives only 9% of the time, but he had more false negatives, where he underestimated the extent of the caries. Overall, 23% of the enamel lesions, 52% of the small dentinal lesions were diagnosed correctly. Of the large dental lesions, 100% were diagnosed correctly. And you can see radiographic interpretation of occlusal caries is a slippery slope. It's very difficult to do. The quality of the radiograph is very different clinically than what we can make with extracted teeth on a benchtop. The quality of the sensor we use, the distance the sensor is away from the tooth, shooting it through the bone, through the soft tissues, through the cheeks, aligning the radiograph correctly are all confounders that make it difficult to get an accurate diagnosis. What about secondary caries using a radiograph and correlating it with clinically defective restorations? And this was a clinical study done at UCLA and reported and published in 1993 in the Journal of Dental Research, where close to 6,300 restorations on 490 patients were examined by 3 examiners. These restorations were deemed to be clinically defective. To make that decision. So of the 6,300 that were examined, 822 of them, 13%, were considered defective. From a radiographic evaluation of posterior teeth using bite wing radiographs, 14% of these teeth, 113 of them, and that's 14% of the 822, had radiographic secondary caries. Of the other teeth that were looked at, and that would be 5,463 teeth where the restorations were intact, 5% of them, 253, had radiographic secondary caries that could be viewed on the bite wing radiograph. What was interesting from the data was the likelihood of radiographic caries, recurrent caries, and seeing it under a defective restoration was 3 times higher. If the restoration was defective, we could see that it was broken or it had an open margin, as compared to a restoration that appeared to be completely intact. 86% of the defective restorations with no radiographic evidence of secondary caries. So 86% of these restorations that were defective, you couldn't look at a radiograph and make a decision that there was secondary caries. It suggests that replacement of defective restorations because we're suspecting secondary caries may be over-treatment. In fact, when you do your treatment plans and you're making decisions to replace restorations, what I want you to keep in mind is go ahead with the treatment plan. Someone signing off on it, a licensed dentist, someone who's been trained. And when you're removing restorations, make a note. Did you see secondary caries along the cavity wall? In fact, in future lectures, e-lectures, we'll talk about some of the criteria that's been viewed to help us make that decision as to whether restorations are at risk. What about the class 1, the facial or lingual pit, the buccal pit? Do we need a restorative intervention? And if you look, our decision making is very similar. With no caries, we consider reevaluation or a sealant, although sealants are perhaps not as well indicated for posterior lingual fissures or buccal pits. For that minimally isolated carious pit, we're going to do a preventive resin restoration with a flowable composite. As the pit becomes more extensively carious, we're going to go with a conventional composite resin or amalgam restoration. No matter if the pit and fissure is on the buccal or lingual surface, or if it's on the occlusion, the consistent repeating message should be, is this surface at risk, in putting all the factors together? We know from the evidence that buccal and lingual pits, posterior teeth, do not hold sealants well. In fact, the sealant durability is usually poor in these surfaces. It's probably due to the forces that they undergo, which are stressful forces that shear the sealant off from the tooth, peel it from the tooth. as compared to an occlusal sealant, is well protected on the surface. Look at carry susceptibility. Remember that topographically, a fissure on the lingual or buccal won't be as at risk for the same appearing pit and fissure on the occlusal because of how food is packed into them. And if you do make the decision to restore, consider a more invasive preparation design and not just adhesive and sealant, but go in and prepare the tooth slightly to get better adhesive retention of this preparation restoration. So our decision making for buccal or lingual pits and fissures is also based upon that anatomy, whether it's invaginated or whether it's a groove. The lingual of maxillary lateral incisors is a very common area to see lingual pits in the anterior. For molars, mandibular molars, buccal pits. For maxillary molars, the cusp of carabelli. For maxillary molars, the lingual extension from an OL, as we see in this clinical picture on the right. On the distal and occlusal pit and fissure, extending onto the lingual surface. And once again, we're looking at the staining and discolorations to make that decision, the appearance of that invagination, the patient's history of fluoride usage, how they're keeping it clean or maintaining it, and their diet considerations. Notice if there are other restorations present that will help us in making that decision. When we're making the decision for treatment planning restorations for posterior teeth, we need to start with a correct diagnosis. From that diagnosis, we can take many different types of interventions. For direct placement of a restorative material, it might be composite, might be amalgam, might be a flowable composite, might be a sealant. Choosing the restorative material that's appropriate for the given circumstance and for the appropriate condition. You've been listening to and watching an e-lecture on decision-making and restorative interventions, Module A, Class 1 Caries and Preparation Design Considerations.